So the work that I presented at ASCO this year was the FIGHT randomized phase 2 study. This was a study for gastroesophageal adenocarcinoma that was either overexpressing FGFR2b by immunohistochemistry or showing circulating tumor DNA positivity for gene amplification. So either or. And the study was previously reported for the primary endpoint, the intention to treat analysis, progression-free survival at GI ASCO this year. And what we presented at this meeting was updated information in terms of subgroup analyses, demographics like gender, age, sex, and whether or not patients had a dose of FOLFOX chemotherapy or not during screening, as well as the molecular subgroups in terms of those patients who had ctDNA positivity and their outcomes, and those patients who had IHC positivity only, for example, in their outcomes. And then we presented the median overall survival, which previously had not been reached at the first data cut, and with the new data cut more recently, showing the median overall survival by the intention to treat analysis, and then also by pre-specified secondary analyses of expression level by 5% of tumor cells or higher, or 10% of tumor cells or higher. And then finally, we updated some information about the corneal toxicity AEs that were noted, and some of the other nuances about that. So overall, what we showed was that by subgroups and all of the subgroup characteristics and molecular profiles, that there was a benefit across the groups. There was more profound benefit in the ctDNA positive tumors, as might be expected, but even in tumors or patients that had tumors that were IHC positive but ctDNA negative still demonstrated improved PFS and OS with a hazard ratio of 0.66. And in contrast, the ctDNA positive tumors had a hazard ratio of 0.1. Then the big news, I think, was the overall survival, which again had not been reached previously. Now, in the intention to treat analysis, was 19.5 months in the Bemarituzumab arm compared to 11 months in the placebo control arm. And in the 5% or higher cutoff of expression, it still had not been reached, which was upwards of 70%, 75% of all the patients. And then 10% or higher cutoff, which was about 62% of all the patients, the median overall survival estimate was around 25 months. So quite outstanding survival in a randomized placebo-controlled global study. And then the corneal toxicities, we noted that any grade corneal toxicity occurred in about 67% of patients, and it was around evenly split, 20%, 20%, 20% approximately for grade 1, 2, and 3. And then we also presented the median time to onset of grade 2 or higher corneal toxicity, which was around 24 weeks. And the median time to resolution to at least grade 1 or lower corneal toxicity was also around 19 weeks. So I think the significance of that is that with that long lead time in terms of developing a grade 2 toxicity, that there may be possibilities to mitigate that with some prophylactic measures, which were not done in this study, but certainly will be assessed in future trials. So the next steps for this program then are to, well, first of all, the publication of this is in the works to really get down to all the details and to really show the efficacy and highlight that in terms of an improved progression-free survival as the primary endpoint, response rate increase of 13% in all comers, and then increased by the higher threshold cutoffs of the biomarker, 18% higher response rate and a 10% threshold of expression. And then the median overall survivals, which are outstanding. And so then secondly, prospective studies in the first line setting, a randomized phase 3 study is planned to sort of confirm what we've seen here in this randomized phase 2 study. So we look forward to that in the very near future. One other sort of thing to add now in this ever-changing and rapidly changing landscape of first-line therapy for gastroesophageal adenocarcinoma is that, not that long ago, when the standard of care for all comers was chemotherapy, and then we were introduced to HER2 positivity for about 10 to 15% of patients. Today, we have a number of candidate biomarkers with very promising efficacy endpoints, including Bemarituzumab for FGFR2 positive tumors, and others as well, including Claudin potentially, which has phase 3 studies, and of course now with immunotherapy checkpoint inhibitors, certainly for PD-L1 high tumors and MSI high tumors. And so we have choices now, and it's going to be really paramount for us to prioritize therapies for our patients, to give each patient their best choice based on their biology and their cancer. And I think that it's very exciting times that we have this choice. And the other point is to say that the future studies will now be looking at potential combinations of these various targets for these various subgroups.